An introduction to critical care, presented by me, your host, Pat Nelligan. We're now going to talk about the assessment of the central nervous system. Assessing the central nervous system. In a previous tutorial, I mentioned the bedside rapid assessment of the CNS, and that's the AVPU system. Awake, responding to verbal commands, responding to pain, and unresponsive. And when we come to a patient's bedside, we ask the nurses, where is the patient on the scale? Is the patient awake? Beyond that, we also want to know if the patient is moving all four of their limbs. This is important because it's really problematic if you have a patient who isn't moving an arm or a leg. We don't know if the patient is injured or not. We don't know where the level of injury is. And oftentimes the level of consciousness is too low to do a proper formal neurological exam. We also want to know if the patient is coughing or gagging, because that means that they can protect their airway once we extubate them. So how do we do a neurological assessment? Well, the first question you must ask is the patient receiving sedation. If the patient is not receiving sedation, then the assessment tool that we use is the Glasgow Coma Scale that gives us a Glasgow Coma score. If the patient is receiving sedation, then we use a scale known as the Richmond Agitation Sedation Scale that gives us a RAS score. The Glasgow Coma Scale was developed for sequential reproducible assessment of patients with traumatic brain injury, even though it's used all the time for all kinds of stuff. The original reason for this was for the neurosurgical brain injured patient who came into the emergency room, and it was developed by Teasdale and Jennett and published originally in July 1974, so this scale is 50 years old. The modern version of the Glasgow Coma Scale goes from a maximum of 15, where the patient is completely awake, down to 3, where the patient is completely comatose. There is no number below 3. There seems to be an inflection point at around 8, where below that number, the patient is seen as having a severe traumatic brain injury, and above that number, the patient has a moderate traumatic brain injury. And obviously, the higher that number goes towards 15, the less severe that brain injury is. An example of how you work the Glasgow Coma score is as follows. You can receive a call from the emergency department to see Niall. Niall is 45 years old and he fell off a ladder, and he has a small traumatic subdural hematoma and traumatic subarachnoid hemorrhage. His Glasgow Coma score is 12, and that's quite reassuring. However, 2 hours later, Niall's GCS has fallen to 8. This is a significant deterioration, suggesting worsening cerebral edema, and he will need to be treated with hypertonic saline and or mannitol, perhaps a ventriculostomy, and further down the road, possibly a hemicraniectomy. So it's a really useful tool for neurosurgeons evaluating how sick a patient is when they get a phone call, particularly from a peripheral hospital or indeed from their own emergency room or neurosurgical ICU. But of course, the GCS score is used all over the place. It's used for all kinds of comas. For example, sepsis, including CNS infections, hypercarbic narcosis, overdoses, hepatic encephalopathy, uremia, stroke, or the prolonged effects of sedation long after the sedatives have gone. The way the Glasgow Coma Scale works is that there are 3 components to it. The first one is the best eye response. Now this is out of 4. 1 scores no eye opening, 2 eye opening to pain, 3 eye opening to verbal commands, 4 eyes open spontaneously. What happens when the patient refuses to open their eyes? Well, sometimes that number is quoted as an E for eyes closed. It's a little bit unhelpful. The second component of the GCS is best verbal response, and this is out of 5. A patient who is orientated will score 5, confused 4, inappropriate words 3, incomprehensible sounds 2, and no verbal response 1. Now there's a problem with this, because if a patient has an endotracheal tube in situ, well then they can't talk, they can't communicate, they can't even make incomprehensible sounds. So often the GCS in a patient who is intubated is scored with a T afterwards. The most important part of the GCS system is the motor response. It rules. It is by far the component that those of us who work in the ICU are most interested in hearing about. And the motor response is scored out of 6. 6 is scored by a patient who obeys commands. If they localize pain, they get 5. If they withdraw from pain, they get 4. Flexion to pain is 3. Extension to pain 2. And no motor response, no movement, nothing scores 1. What we are looking for here, in general, in the ICU, is patients who score a 5 or a 6. Look at the motor score, because this is the bit where we know that they're actually able to do stuff, and you don't have the problem of the speaking and the eye opening. Of course, patients who are delirious may not obey commands. Ideally, the score is presented in its component parts: best eye opening, best verbal response, best motor response. If the patient has been given sedation at any stage or is agitated, we use the RAS scale, the Richmond Agitation Sedation Scale, and this is named after the city of Richmond in Virginia, where it was developed. If we look at the causes of apparent coma in the ICU, brain injuries such as stroke or traumatic brain injury are a relatively small proportion of those patients. Critical illness itself does cause coma, particularly sepsis and hepatic encephalopathy and all kinds of other metabolic dysfunctions associated with just being sick. But the vast majority of patients who are unconscious in the ICU are comatose as a consequence of sedation. Now, that sedation may not be currently running in the patient because some of the drugs that we give as sedatives have very long terminal elimination half-lives. And indeed, the context-sensitive half-lives of some of these drugs can be quite long as well, particularly in the setting of acute kidney injury. The scoring system that we use to look at sedation is the Richmond Agitation Sedation Scale. It's very easy to use, but can be a bit confusing because of the undesirable extremes that are at the top of this scoring system and at the bottom of the scoring system. So I'm going to just mention a couple of the problems with the scale first. Although the RAS score is really straightforward and easy to use, you must be aware that it really contains 3 components: a sedation gold score for titrating sedatives, a coma score, because let's face it, rarely is unarousable a goal. So most of the time that represents abnormal physiology, and an agitation scale that always represents abnormal physiology. I'm going to split the scale in half because it is easier to visualize from this perspective. The first component is the sedation scale, and that goes from 0, which is alert and calm, to -5, where the patient is irresponsive. In between, there are different levels of either sedation or reduction in consciousness, and this is important. For example, 0 to -3 is the desired range for sedation for most ICU patients. At -3, the patient will move around the bed gradually, respond to voice, and, if not intubated, protect their airway. -4 is movement to painful stimuli, and -5 is the equivalent of a GCS score of 3. That might be your therapeutic goal in advance of administering neuromuscular blockade, but it is the equivalent of general anesthesia. If this is not your goal, this represents excessive sedation. The Richmond Agitation Scale goes from the same 0 to +4, reflecting progressively worsening levels of agitation. Ultimately, that agitated patient may be a danger to themselves and to staff. As a therapeutic model, you might try using sedatives to reduce that patient from +4 to a lower level on the plus scale, but I suspect that we want our patients sedated to a -2. So the agitation part of the scale really has no therapeutic component, but it's really useful nonetheless when we're handing over patients about the degree of agitation that the patient has. If a patient becomes acutely agitated, it is imperative to ensure that they're not in pain. The situations in which you should consider pain to be a problem are patients who've had recent surgery or those who've been involved in trauma, particularly if they have fractured ribs, wounds, chest tubes, etc. If you're not sure, give the patient a bolus of opioid and see what happens. You should also consider a full bladder due to ureteric obstruction. This is a huge issue post-operatively in the recovery room where patients may become very agitated and they can't tell you what the problem is. The other thing you should always consider is withdrawal syndrome. It's somebody who's been in the ICU for a while, and that's withdrawal from opioids, alcohol, benzos, and all kinds of other drugs. Once you've eliminated those obvious things, then you need to confirm or disconfirm that the patient has delirium by performing a CAM-ICU score. The majority of the patients who are agitated in ICU are in fact delirious. That is acute integrated brain failure. This waxes and wanes during the day. It often manifests in the evenings and overnight. It's caused by a whole range of physical, metabolic, and environmental issues, not least sleep deprivation, and it needs to be carefully diagnosed. In particular, one needs to eliminate those drug and alcohol withdrawal problems. The reason why you really have to outrule withdrawal is because if you give opioids or benzos to a delirious patient, they get worse. The mechanism by which you confirm or disconfirm delirium is by performing a CAM-ICU screening score. And this is the flow sheet for doing CAM-ICU. There's fluctuating mental status, and so then you ask the patient to follow a series of commands and they squeeze your hands when the letter A is mentioned. If they make a lot of errors, then you do a RASS score, and if there's evidence of the RASS score being either positive or being 0, then you can ask a series of questions to see how the patient responds. And if they make errors, they are likely delirious. I often find that the ICU nurses will just tell me that they're delirious, that they're so familiar with this particular problem that they know it almost instantaneously. Patients suffer in ICU, and you need to quantify and evaluate their suffering using a system. The system I use is the PAID or PAID approach. If you're familiar with the guidelines for analgesia and sedation from SCCM and other organizations, their version is called PADIS. I think it's excessively complicated. This is more straightforward. So we have PAID. P is for pain, A is for anxiety and agitation, I is for insomnia, and D is for delirium. These are the 4 major problems that the patient has neurologically. Let's look at pain. Pain is quantified using some form of visual analog score, or perhaps the patient is grimacing and the nurse's intuition tells them that the patient is in pain. And for this, the treatment is an inverse pain pyramid. When you're a medical student, you're told to start with mild analgesics and work your way up. That's not how it works in perioperative medicine and in critical illness. We start with the strong stuff and work our way backwards. So we have our inverse pyramid. The top of the pyramid is stuff that just stops the patient feeling pain. They are regional nerve blocks and neuraxial blockade. What I mean by that is epidural and paravertebral blocks. Then we're going to use long-acting opioids such as morphine, hydromorphone, oxycodone. Subsequently, lidocaine infusions or patches are quite useful. Then we have paracetamol, acetaminophen, and non-steroidal anti-inflammatory agents, and then other agents that do have analgesic effects such as ketamine and clonidine. And sometimes the patient is just really anxious and that anxiety is worsening the pain, so occasionally we'll give them some benzodiazepines and other local voodoo things that people do, like giving, for example, magnesium that's not really based on any clear evidence. It's important that if you start patients on opioids, you need to wean them really carefully. Long-acting opioids collect in the body, particularly morphine that has active metabolites. So once pain is controlled, that dose of morphine needs to be reduced. Unfortunately, tachyphylaxis is a real problem with the use of short-acting opioids in the ICU. That's fentanyl, remifentanil, alfentanil, sufentanil, and frequently they stop working at an early stage, but the patient gets horrible withdrawal symptoms. As a consequence, you might need to use methadone in those patients to remove them from opioids. A is for anxiety and agitation. When we do our RASS score, we ask ourselves, is the patient agitated? If the patient has a positive RASS score, say for example in the region of +1, this is likely just due to anxiety, and anxiolytic agents are required. If the patient is truly agitated, then you ask yourself, is the patient delirious? And if they are not, then we give them sedatives. Sedatives are also usually required in the early phases of mechanical ventilation, irrespective of anxiety and agitation. Most anxiolytics are benzodiazepines. These are generally administered orally or intravenously by bolus. Typically, they are long-acting agents, diazepam, lorazepam, and alprazolam, and it is inappropriate to treat anxiety with continuous infusions of these drugs. You give them when the patient needs them. Occasionally, a small bolus of midazolam is given, but this is a relatively short-acting agent. In terms of sedatives, these are used to treat anxiety and agitation and help with toleration of the endotracheal tube. The first-line agent is propofol. Opioids are usually not required when propofol is administered, as patients can tolerate an endotracheal tube with a propofol infusion. For lighter sedation, dexmedetomidine has become popular over the past 2 decades. Patients cannot be deeply sedated or rendered into general anesthesia with dexmedetomidine. Continuous infusions of midazolam, often with morphine, are used in very limited situations. For example, if propofol is causing significant hemodynamic disruption, particularly hypotension, or the patient just cannot be sedated effectively despite high-dose propofol. But be aware, outcomes with midazolam or other benzodiazepines for continuous sedation are worse than they are with short-acting sedatives like propofol. When discussing sedation, use the DREAM approach. D is for the dose of the sedative in micrograms per kilo per minute or mils per hour. Or is the reason for sedation. Why is the patient getting sedated? E is for evaluation of the depth of sedation using the RASS score. A is for the aims, and that represents the goal of the RASS score. For example, we're aiming for a RASS score of -2 or -3. The patient may have a RASS score of 0 or -4, for example. M is to minimize. What are you going to do to reduce the number of drugs and the dose of those drugs? So, for example, if the patient is receiving 40 mics per kilo per minute of propofol to tolerate mechanical ventilation with a goal of -3 in the RASS scale, we are going to try and wean that propofol by 25% per day. This is particularly important if the patient is receiving opioids like morphine and benzodiazepines. I is for insomnia. Insomnia, loss of sleep, is a major problem in the ICU. This is because of relentless noise, lights, activity, interventions, people speaking loudly. The patients lose their circadian rhythms. They also have lots of circulating catecholamines due to stress, which interferes with sleep patterns. Drugs like opioids and benzodiazepines devastate sleep architecture, and sleep aids in general don't work very well. The best way to treat insomnia is to prevent it by giving the patient a day-night cycle. You can help them along using agents like melatonin or zolpidem, but the best thing to do is minimize the noise, give the patient lots of exercise during the day, stop interrupting their sleep by examining them or evaluating them, and sometimes we'll use low-dose sedatives like propofol or dexmedetomidine. But the most important thing is to keep quiet and turn off the lights. D is for delirium. It is imperative that you do not confuse delirium with withdrawal from alcohol or prescription drugs or recreational drugs. These are the big ones: alcohol, opioids, benzos, gabapentin, and various different psych medications. If the patient has been on psychotropic medications before they came into the ICU, these need to be restarted or replaced by something that can be given intravenously. The mnemonic that I use for the treatment of true delirium is SEND, S-E-N-D. S is for sleep. If you get the patient to sleep and restore circadian rhythms, magically delirium usually goes away. You also need to really work hard on the environment to ensure that the patient knows where they are, that their lights are turned off at night, that somebody is at the bedside telling them where they are and what's going on, their family are let in to talk with them, that they have their hearing aids on, that they have their glasses, etc. You sometimes need neuroleptic agents to assist with restoration of brain function and to tamp down a lot of that abnormal electrical activity. And we also use dexmedetomidine as an agent that helps with delirium. This is an algorithm for managing delirium in a CAM-positive patient. The first question you have to ask is the patient able to take tablets? If they're not, you're very limited with your interventions. And so what we tend to give the patient is haloperidol, 2.5 to 5 milligrams every 6 hours intravenously, and perhaps more for rescue therapy. If the patient is able to take tablets, then olanzapine is given 5 milligrams at night and then increased to 10 milligrams BID. Keep in mind that these agents all increase the QT interval and may increase the risk of patients having arrhythmias. You may also start the patient on a dexmedetomidine infusion. This is started at a low dose and can be increased progressively. Now, I will frequently encounter nurses and other healthcare professionals telling me that there is a maximum dose of this particular agent. I find this a bit curious because there doesn't seem to be a maximum dose of propofol, and we frequently give patients a higher than recommended dose of dexmedetomidine before that patient will respond. And that's because everybody's brains are different, and also patients' responsiveness to sedative agents are different also. Now let's quickly review this tutorial. This was a tutorial about neurological assessment. I started with a discussion about the Glasgow Coma Score, then I went on to the RAS score, then the CAM-ICU score, and then the PAID, the paid approach to the problems that we see in the ICU. And those problems are pain, anxiety and agitation, insomnia, and delirium. In the next tutorial, we're going to move on and discuss the respiratory system, or pulmonary care. This is going to require 3 tutorials. The first on basic respiratory blood gases and why they're important, basic ventilator settings to understand the blood gases, and basic chest radiography. Join me then and I guarantee you'll learn something. Thanks for watching this video. If you enjoyed it, please subscribe at YouTube or follow me at ccmtutorials.org. Give me lots of likes and leave some comments. If there are any topics you specifically want me to cover in future tutorials, just send me a text or a comment below.